Parkinson's. That's just the title that came with it. All right. In your Nurse Think NCLEX RN conceptual review for whatever this is, if you look on page 364 and 365, there is a tremendous summation of Parkinson's disease. It goes through the patho. 364, 365. Patho, assessments, labs, interventions, nursing implications, medications, discharge, and education. Lewy bodies. All right. Now, in your med-surg text, it's on page, starts on page 853 and goes through (859). It ends on 859. So it's not that much to read. Make sure that you know the nursing alerts. They say QSIN. There's a few of them on there. There's best practices for safety and quality care. A comparison of Parkinson's and Huntington's. Don't worry about Huntington's. So, not that much to read. All right. So what is Parkinson's? What is Parkinson's? What kind of neurodegenerative disease? Progressive. You know, like the insurance people. Everybody owes them money. So what do you, when we say Parkinson's, what do y'all think of? The what? The shuffling gait. How many of y'all are old enough to remember a song called the Curly Shuffle? Oh my God, never mind. Well, this is the Parkinson Shuffle. No, we can't Cupid Shuffle because that causes too many issues. I ain't got no rhythm, and y'all would start throwing anti-seizure medicine at me. But that's, what else do you think of when you think of Parkinson's? Who? The flat affect. You know, kind of like y'all are. What else? The tremor. That's why you always hire a Parkinson's patient to make milkshakes. And if they're good, they can do it on both sides. Do what? New Balance, not house shoes. Why? They trip. They also need a bunch of little dogs and rugs and cords, right? Good, because we're going to talk about that in a little bit. How many stages of Parkinson's are there? 5. If you don't believe me, we shall open up the book to chapter 39, verses 83 through 102. Box 39-1, the stages of Parkinson's. Stage 1, the initial stage. Y'all find it? Tell me what it says. Okay, unilateral. What does that mean? One side, so they're like this. Right? No. The symptoms are mild. Okay? So we'll talk about all this, but just understand that it's progressive until we get to stage 5 when they're what? They are completely helpless. Complete ADL dependence. You know, just like them babies. So, all righty. Ooh, another one, Parkinson's disease. I love these things.
Parkinson's disease, which is sometimes called Parkinson disease, Parkinson's, or PD, is a movement disorder where the dopamine-producing neurons in the substantia nigra of the brain undergo degeneration. Parkinson's is one of the most common neurological disorders. It's a progressive, adult-onset disease, and it gets more common with age. Most of the time, there's no known cause, but in a few cases, there might be a genetic cause, like mutations in the PINK1, Parkin, or alpha-synuclein genes. And in rare cases, Parkinsonian symptoms might be caused by MPTP, a toxic impurity that can be found in the recreational drug MPPP, or desmethylprotein, which is a synthetic opioid.
Sign up for a free trial today and watch the full video on osmosis.org.
Okay. We'll just press on. All right. Cognition and mobility, pain and infection. They're all related to Parkinson's. So specifically the cognition and mobility. That's what we're focusing on right now. Because you'll see a lot of Parkinson's patients also have cognition difficulties as the disease progresses. There is a they don't know what causes it, but it affects more men than women. And it usually, the onset's over about the age of 50, but we'll get to that too. All right, genetic, it says 40 here, and it tends to run in families. And it's one of those, it's like an Alzheimer. It's not like Alzheimer's, but the effect on the family is similar to that, because you have this person who is really well functioning, and all of a sudden they just start this decline. With Parkinson's, it's primarily movement and being able to take care of themselves. Of course, with the other one, they forget who they are, who you are, and all that kind of fun stuff. But once it sets in, it develops or progresses at a rate that's just for that patient. Some people may go years and years and years with mild symptoms and then just have a rapid decline. Some of them have a constant decline. It's very individual. 60,000 new cases a year. 1 million live with it. Is that really true, though? Because if I got Parkinson's, my whole family's living with it. Because that's what it's going to take. And it affects 50% more men than women. All right. You always want to find out the history. We always talk about our assessments. When did the symptoms start? When did you first notice them? Resting tremors in the upper extremities. That's those mild symptoms that people might overlook. What do people usually think it is when Papa's sitting there and that hand's shaking a little bit? He just old. He wore out. But it is. It's mistaken for natural aging, and it's not. If you don't tremble when you're young, you should not tremble when you're old. Rigidity assessments, that mask-like facial expressions is a hallmark symptom. Emotional changes. Bad people will get ugly when they have Parkinson's. Why do you think that is? They're frustrated. Why do you think they're frustrated? They're losing their independence. They can't do what they're used to. One of the tests that they do for Parkinson's, this is dry erase, is they get them to write things with their trembling hand, and you'll notice, that's pitiful. It'll be A, B, C, D, E. And as they write, because of the tremors, the print gets smaller. That's just a sign and symptom. It's a test. They'll have emotional changes. They'll have speech changes. How much of this could be drug related? I mean, you're on some pretty strong drugs, ain't you? And bowel and bladder changes. Sounds like we're going back to infancy. And that's exactly what we're doing. The problem with Parkinson's is there's no test. It's symptom, they'll do a CT, but there's nothing that says this is Parkinson's because you have A, B, or C. So you have to base it on the patient, their history, their symptoms, and then you treat it. And there's a bunch of things that you do to treat this. Mostly medications. What other things do you think that we're going to do to help these patients with Parkinson's? Who? Safety. Well, that's a big thing that we're going to have to do for them. But what kind of, that's it, therapies. What kind do you think they're going to need? PTOT speech. PTOT speech, right? Why PT? Okay. In a general question, what does PT work on? Mobility, gross motor skills, right? Walking, hitting, golfing, whatever. What about OT? Fine motor skills. That's where your ADLs come in. I mean, do you think it's kind of hard to brush your teeth when you got Parkinson's? Well, I mean, if you get it in your mouth and you got the tremors, you got an electric toothbrush now. Do what? Yep. Yeah. It's like a gyroscopic spoon. The hand is like this, but the spoon is steady. That's the coolest thing I've ever seen. What kind of toilet seat do they need? A raised one. Okay. So, but they're going to need all these therapies because it's going to be a progressive decline. Like I said, there's no tests and all that other kind of good stuff. So. All right. Do you think you would recognize that expression? Of course, you'd probably want to know him beforehand, what he used to look like. Did he have teeth? But they have that blank mask. It's just weird because it's like they're there, but they're not there. And that's one of those things. Do you think that's an early or a late or intermediate? It's going to be intermediate to late. Because what's going to be your first signs? That single-sided tremors and that kind of thing. Because as it progresses, things just get worse. Excuse me. All right. The things that we're going to have to help with is this decreased mobility. And they're not going to be able to take care of themselves. They're going to require constant care after a certain point. Now, they will be able to adapt to certain things, but they're going to be, honestly, it just kind of sucks for them and for the caregivers because this independence is slowly slipping away. Sorry. And it's going to be due to muscle rigidity. What's the difference between akinesia and bradykinesia? What does A mean? None. What does Brady mean? So we're talking about movement, right? Kinesthetics. So if I'm akinesic, what's wrong with me? Nothing? I can't move. And if you watch these people walk, it's like they get frozen. But that progresses from that bradykinesia that they have. They have tremors. They have gait changes. Y'all have seen them stooped over when they walk, right? They have impaired cognition because the brain ain't it's transmitting, but there's a balance between acetylcholine and dopamine that's creating an issue. The acetylcholine is wanting you to do this. And the dopamine is saying, hey, calm down. Let's get it under control so we can have purposeful movements. But what happens is we get a lack of dopamine and the acetylcholine wins. So now there's no retardation of the movement, so that's why you get your tremors. And because of that, you have an impaired cognition as well because those neurotransmitters are off balance. Okay. So we want to do certain things. We want to do non-surgical management, and then we got surgical management of them. What's non-surgical management? PT, OT, ST. That's non-surgical. We didn't have to take out a knife and cut them. What else? Medications. Like what? Methyl-dopa, carbidopa, levodopa. All them dopes. What's the problem with medications in Parkinson's patients? Yeah, it can cause that. What else? Do what? They can do that too? Who? Well, do that. What else? Well, that's kind of on us as nurses. How come people have to go from Lortab 5 to Lortab 7 to Lortab 10 to Lortab 27 to Lortab tolerance? The body builds up resistance to it, so they don't work as good. Because if it did, we could keep giving them the carbidopa, levodopa for the rest of their lives, and their symptoms would be managed. You realize we can't cure this, we only manage symptoms, just like everything else. So in order to combat that, they'll do what's called a medication holiday, and you got to watch them for 7 days to help the body kind of get used to not having it and then putting it back in to help manage these systems, or these symptoms, not systems. But it's all about management. It's no cure. How many of y'all have seen Michael J. Fox recently? Y'all remember him in Back to the Future? Where he was like young and people wanted to be him? He looks terrible now. He's very gaunt. He has, very little control of any movements. He's hanging in there though. So, that's what a Parkinson's patient has to look forward to. Okay. We're going to go through these stages real quick. In the initial stage, they're going to have that unilateral limb involvement, minimal weakness, and hand and arm trembling. In the mild stage, it's going to be bilateral limb involvement, a mask-like face, and a slow shuffling gait. That's probably where people start noticing it more, is because of their gait when they walk. Then you're going to have postural instability in stage 3 and increased gait disturbances. That means it's just getting worse. Then they're going to have akinesia and rigidity, and then they're going to be in the bed. So knowing how it progresses can help you teach that family what to expect. Because isn't the unknown the worst thing? So now it's all about managing all their dysfunctions. Home care preparation, self-management education, and healthcare resources. Who does all that? Who? We do. Because when they leave they're going to be in the hospital for a little bit running all these tests, running up that big bill so we get paid. And then we're going to get them ready for discharge. And we're going to have home care preparations set up. What are some things that they're going to need? Huh? She said a walker, assistive devices. Okay, if I'm in stage 1, do I need all this? No, I didn't say what stage. But here's the deal. They're going to need stuff from the get-go, right? If you notice that they're trembling and you know that they're going down to Parkinson's Road, what are some things that you're going to teach them? What do you think that they're going to need? How about things like get the cords up off the floor? Get rid of that little stinking dog that yaps and bites people's ankles. Get the rugs up. Put some hallway lights in. Safety, safety, safety. Because as it gets worse, you're going to need it more and more. And it's going to progress to the point where you're going to need the elevated toilet seat. You're going to need the walker. You're going to need the gyroscopic hand tools so he can feed himself or herself or whatever. You're going to need that speech therapy to come in and evaluate their swallowing. You're going to need all this other stuff, but it's going to be progressive when you do it. So when you start out with these patients, start with their safety first and keep that in mind with everything. Self-management education. They're going to get to a point where they cannot take care of themselves, but as long as they can, you promote that self-management. I don't want to eat. It's too hard. Remember when you told your kids, shut up and eat it? It's good for you. Builds muscle. Y'all didn't tell your kids that? Lord have mercy. I'm like the meanest person ever. You see that piece of cabbage? You're going to sit there till you eat it. Cabbage will be cold and wilted and still sitting there. Eat that. But you're going to have to give them extra time. When you ask them a question, you can't expect an answer right then. Because they're having cognitive problems. But you're going to have to do that. But you're going to have to teach them, as long as you can do it, Sugar Bear, you're going to be doing it. I ain't wiping your butt. You got 2 hands, 1 butt, you could reach it. You ain't shaking enough to not reach it. Sometimes it's hard, isn't it? We want to help, we want to do, but that's a disservice to your patient. So you'll teach them how to do things up until the point when they absolutely cannot, and you still want them doing as much as they can. And then you want to hook them up with the resources. You want to hook them up with the DME equipment. You want to hook them up with the therapists and everything else. You're going to make sure that they take their medications on time. You're going to make sure that they have all the stuff that they need to function safely. And they're going to know where they can go. And even after you discharge them from home health, they're still going to call you. So what do we want to do? We want to improve. This is like the dumbest thing I've ever seen. Because anytime we have a disease process, what do we want to do? We want to mitigate it, right? We want to improve mobility to provide self-care and not experience complications of impaired mobility. Duh! We want them doing as much as they can for as long as they can. That's all it says. And we're going to do everything within our powers to help them get to that point. And we want them to be safe. And we want them to have a quality of life. Laying in a bed with 74 tubes stuck up in you in the fetal position, is that quality of life or not? We don't get to decide. Some people think it is, some people think it isn't. Personally, I'm going to keep my mouth shut because I will get in trouble. Okay, we're going to ask a question. The nurse notes that a client with Parkinson's disease has resistance to passive movement of the lower extremities with mildly restrictive movements. Which documentation will the nurse use to describe this assessment finding? How many say A? Plastic, that's what you get in California from them surgeons that make too much money. Cogwheel. Huh? You hit them with a lead pipe. I told you to walk. It's rigidity. Resistance to passive movement. They're rigid. You know, like this. Y'all have never, that's going to be burned in your brain now. Mr. Hill's arm's stuck up here. He's rigid. Rigidity, cogwheel. Total resistance is lead pipe. That's really when you want to hit them, though. But the other thing is when we're dealing with Parkinson's patients, ooh, that was Alzheimer's. We're just going to get all confused. In your book, look at 856, Best Practices for Patient Safety and Quality. Allow the patient extra time to respond to questions. Remember, their cognition isn't as good as it used to be. Administer promptly on a schedule to maintain continuous therapeutic levels of drugs. What does that mean? Do what? Give them their drugs on time every day. Now, I did see, or there's a video where they have to individualize the treatment to the patient. And the patients need to be aware that their physician may be doing that. It's not a perfect system, but it is always better to maintain that therapeutic level of drugs in their system to make sure that we minimize the symptoms. Like I said, we ain't curing nothing. We're just trying to keep them going as long as they can. And by keeping their therapeutic levels up, we can do that. Provide drug therapy for pain or tingling limbs as needed. What kind of drugs do we give for pain and tingling limbs? Gabapentin. Everybody and their mama's on gabapentin if they have Parkinson's and or what? Diabetic neuropathy. Arthritis? So what are some side effects of gabapentin? Do what? I don't know. Hey, just take it. They'll be all right. If you give a medication, know your side effects. Because Parkinson's patients are especially prone to postural hypotension. What does that mean? When they stand up, they fall out. That ain't good on a good bad scale. So what we need to do is make sure that they're staying what? Safe. How do we do that? Get up slowly. Or just make them sit there the rest of their lives and get a big bed sore on their butt. That'll always work. Safety. Rise slowly. Get your bearings about you before you try to take a step, Papa. You'll end up face down. Okay? Patients admitted to your floor. You think they're going to be on fall precautions? You better be, or you're going to lose money. Parkinson's patient come into the hospital, done fell on their face. There went your raise, Sugar Bear. You can't even keep your patients safe. And that's a big issue, especially with CMS. Safety is always an issue. One of our biggest problems as caregivers is impatience. How long does it take you to brush your teeth today? Well, I hope you brushed your teeth today, but if you didn't, whatever. You're supposed to brush for 2 minutes, right? Isn't that like singing the happy birthday song twice, or? I don't know. Yeah, I guess if you got an electric toothbrush, it's cut in half, or? How long do you think it's going to take a Parkinson's patient to brush their teeth, to feed themselves, comb their hair? It's going to take 40 forevers in a day. But you got to give them that time. We're impatient because we got things to do, places to go, TV shows to watch. They need time because they don't function like they used to. All right. Implement interventions to prevent complications of impaired mobility, such as constipation, pressure injuries, or contractures. When it's more trouble to get them up, that's when you got to get them up. Because have y'all ever seen patients with contractures? Have you ever seen patients with foot drop? Is that how you want to treat them? And the more mobile they are, the fewer problems they have. Especially with constipation. Because most of the drugs we give them, if you look on the side effects, everything constipates you or gives you diarrhea or a headache or a rash. We want to make sure that their diet is good. It's high fiber. They're also going to need protein and extra calories. Why are we needing extra calories? He don't do nothing. Who? He does the shake. I'm using energy. Not much, but I'm using it. No, actually, a Parkinson's patient with tremors is using a tremendous amount of energy. It's almost like shivering. How much energy do we burn when we shiver? We're fixing to find out. We're going to go get in that pool out there at the thing and then get out and stand out there in the cold and start shivering. Have y'all seen these idiots that get out of saunas and get into ice baths? I'm surprised they don't die of heart attacks. But they said that they're supposed to burn energy and lose weight. Well, get your butt on the treadmill, whatever. But it uses energy, so we want to make sure that we're adequately addressing that need. The other thing is we're going to have to monitor them for depression. But Lord, ain't they got enough problems? Well, sure. But ain't nothing worse than I used to be able to and now I can't. Especially with some of these people that have worked all their lives and at 27 would work people to death. At 57 would work people to death. And now they're 62 and they can barely get out of their chair by themselves. It's a hard transition. Sure, you're going to deal with depression. The other issue that they have is insomnia. How would you like to be like this and be tired all the time because you can't sleep? Then they have like micro naps that they don't even realize they took. I read somewhere, maybe in the book, that could be an issue if you're driving. Yeah, I would think so. Although the way I've seen some people drive lately on I-20, I think all of them are asleep. And speaking of depression, what about when you take Mama's keys away from her? Or Papa's keys? And then leave the car sitting in the driveway. Man, y'all are some cruel people. Depression, lack of independence is very real with Parkinson's patients. Had a patient when I was doing home health. Super nice guy. He was in probably stage 2 or 3 of Parkinson's. He was requiring a lot of assistance. He wasn't quite akinetic yet. But his wife took great care of him. Great care. Nice lady. They live right down the street from me. We were coming by and the ambulance was at their house. And I said, oh, he done fell. He done something, because you know that's what you expect when you have Parkinson's patients. So we stopped, and his wife had an aneurysm and died. Well, she didn't die until she got to the hospital, but. And if he wasn't depressed before that, it wasn't 6 months he was gone again. He was gone. So you never know what tragedies may befall your patients. So you just have to do the best you can with them. Some of the drugs, like I said, they may have insomnia or sleeplessness, so they'll give them drugs for that. But they may give them how many of y'all have heard of MAOI inhibitors? Or MAO inhibitors? What are you not supposed to eat with them? Who? Oh. Tyramine, including cheese, aged, smoked, cured food, sausage, red wine, beer. Give them a headache, hypertension. Select all that apply. Patients should continue these restrictions for 2 weeks after they quit them. Just know your drugs when you give them to patients. What's the most common drug for this that we're giving right now? Carbidopa, levodopa. It's supposed to regulate those dopamine levels. But they're also trying medical marijuana. It may not help, but they're a lot happier. Or they don't care. Why would we give them medical marijuana? Who? What are some reasons? What does your book say? Tremors. Dyskinesias, okay. And insomnia. I've seen all the movies. It probably helps with their appetite too. They'd be sitting there with a bag of potato chips. All right. Let's see. They may also experience hallucinations, which is always a good time. What do you do for hallucinations? Do what? For mental health. Y'all remember hallucinations for your, you feed into them? Yes, those walls really are melted. No. What's that phrase that we always use? It's supposed to be like really therapeutic. That must be very terrifying for you. But I can't see it. Tell me more. Oh, that reminds me of that song. Tell me more. No, that's from Grease. Never mind. But you've got to expect all these changes with your Parkinson's patients, and then deal with them as they come up. Like I said, it's only going to get worse over time. So get ready. Let's see. Let's go to the next one. Which one is going to be the primary? Primary expected outcome. What y'all got? How many think A? Think nutrition will be a primary problem? What about elimination? Motor ability. Why? Because motor ability affects all the rest of them. Because if I'm not motoring, I'm not nutritioning in it. Right? If I've got motor problems, I can't get that fork to my mouth. And if I do, I end up with a bunch of puncture marks on my face. If I'm not motoring, I'm constipated. I'm so backed up, my eyes are brown. If I'm not motoring, I can't communicate because my motorings ain't allowing my motors to work. My speeches ain't working. It's all related to motor function, whether voluntary or involuntary. And until you address it, but that's the expected. That's the primary problem with Parkinson's is motoring. Hello? Oh, there are very few things about me. Okay, we already talked about that. Beat that horse dead. Okay. Now this is called gait impairments in the Parkinson's disease people. That's what it says. And hopefully it will play. Or maybe not. Here we go. Oh. Okay, notice the arm swing. Which side is affected? The left. Slower gait. You notice he's kind of off kilter. See, his head's kind of tilting to that way, or his right. Now, is that what y'all typically think of when you see a Parkinson's patient? Look at his stride length. Now, he's motoring pretty good, but his posture sucks. See how he freezes? What they said is they're afraid that their feet, when they lose contact with the floor, they're going to fall. That's why their stride length is so short. So how else can we manage this? We already talked about we're going to drug them up. What else can we do? Surgery. What are we going to do? Cut their heads off?
Osmosis is a powerful health learning platform that aims to build a more caring world and is used by millions of learners globally. Focus, learn, retain, and thrive. Learn more.
Well, that was interesting. Y'all awake now? I am. I think I just peed my pants. So what kind of surgery are we doing to them? It's called a nerve stimulation. It's like they put a pacemaker kind of generator in their chest and then they wire their brain up to stimulate the deep nerves. It's effective, but it's only effective for so long, just like everything else. So what kind of teaching you going to do with that patient with that nerve stimulation thing you stuck in them? Same for any surgery patient. Watch signs and symptoms of infection, all that kind of good stuff. Do they have the same limitations as a pacemaker? No. They just have a similar battery set up. But the other thing is, how can we tell if it works? Do they have decreased tremors? If they're going like this, and then we put a deep nerve stimulator in their brain and they quit, it worked. Their gait problems are improved. Instead of going, they take more normal strides. It's always about the evaluation part. How can we tell if it works? Because if it's not working, why are we doing it? And they'll also do some ablation and some other things, but I guess the latest technology is that nerve stimulation. But you also have to make sure that they're expectations are realistic too. They are not going to be 26 again. This just enables them to function as normally as possible for as long as possible. All right. Y'all think y'all got it? Till I start asking questions, right? Okay. Think about your patients. It's all about them. Your neural tube defects, what are you doing as a nurse? Your Parkinson's patients, what are you doing as a nurse? What kind of challenges do they have? How can I tell if what we're doing is working? What have we done for them?